going to report the overview of what is the rare bleeding disorder and the state of the art of this kind of disorder, which are more rare. The outlines would be the prevalence of rare bleeding disorder, their presentation, diagnosis, association between the laboratory phenotype and bleeding severity, which is not always obvious as hemophilia, and even in hemophilia we have the heterogeneity. Here is even bigger than that. And standardization of the coagulation activity assay and to verify the usefulness of global assays, which few works has been done since now, and what are the available treatment and the development of novel products. These slides have been shown different times, and I think still, as a worldwide data collection, is showing you that about 250,000 at least registered patients are affected with coagulation disorder. And of those, about 3 to 5% are affected with rare bleeding disorder. And here in the lower part, this data is showing the comparison of the European rare bleeding disorder, which has been collected by University of Milan, and World Federation of Hemophilia is showing more and less that the two most prevalent type of rare bleeding disorder are actually factor 7 and factor 11 deficiency, followed by fibrinogen factor 5 and factor 10 deficiency, and then factor 13 deficiency. The most rare cases are factor 2 and factor 5 and 8 deficiency. What is the clinical manifestation, and whether we have to call the rare bleeding disorder as a single group? I think that would be the big mistake. However, because of the rarity and the limited knowledge we are just putting all together, I think this is very important that you start to see each single disease by its own characteristic and to see how is the clinical manifestation in this single group of patients. There is a considerable heterogeneity in this group, and bleeding symptoms like CNS, cerebral bleeding, and hemarthrosis and hematoma actually are very frequent in factor 10, factor 13, and some afibrinogenemic patients. But most typical type of symptom, which is common to all rare bleeding disorder, are the excessive bleeding at the time of invasive procedure. And that's very important for who are not having bleeding during their life, but they're going through the surgery. You have to pay attention how to treat this patient, delivery in women and circumcision in boys that are affected with this type of disorder. How the diagnosis of the phenotype diagnosis has been made, which is also helping you how to follow with the genotype diagnosis. So PT and APTT could be used, and thrombin time usually for the different type of disorder. For example, for factor 11 deficiency, for factor 10, factor 5, and factor 2, you can see that for factor 11 is a prolongation of APTT, we will see in the next slide, and with a prolongation of the PT, you will suspect a factor 7 deficiency, and fibrinogen deficiency is usually prolonged PT, APTT, you can have a prolonged PT and APTT, but that depends of how is the severity, and usually you have to make also the thrombin time. But there is only one single deficiency that you're not going to pick it up if you use only these assays, and that's the reason why it's extremely underestimated, especially in a mild deficiency, and that is factor 13 deficiency, where you need to make a specific type of assay for the activity of factor 13, and also you can make the evaluation of the antigen level. So these slides are available on the site, and I'm not going through every detail of how the prolongation is made. And once you have the PT, APTT, or thrombin time prolonged, you can make a mixing study, and once a specific type of suspicion of a single deficiency has been done, then you can go for the evaluation of that specific activity and antigen of that type of factor. So how much we know? There was lots of study ongoing, and there is one European network of rare bleeding disorder which has been done between 2007 2010, and this cross-sectional project was established to answer those questions on the clinical manifestation of the patient, and also to understand for the first time what was the correlation between the remaining residual factors in circulation and the severity of the bleeding in patients. There was 11 European countries participated in this study, and around 500 patients has been included. And we assigned the category of clinical bleeding severity, and that was, of course, arbitrary. And there was 4 classes: asymptomatic patients who did not have any documented bleeding episode. Grade 1 were those that were bleeding only after trauma or getting some kind of drug ingestion like aspirin. Grade 2 bleeding is spontaneous minor bleeding, like bruising, ecchymosis, minor wound, oral cavity bleeding, epistaxis, and menorrhagia if it doesn't require blood transfusion, so it was not so severe. And grade 3 was the spontaneous major bleeding, CNS, GI, umbilical cord bleeding. I think the most important slides, which has been published last year in the JTH of February 2013, is this slide. And for the first time, however, you can see the intervals are still large, but it's getting you some information more than what we were used to have. And that is showing you that rare bleeding disorder are not only one group of the disorder. There are 3 groups of disorder. Those that there is a very good correlation between the amount of the factor and the clinical severity of the patient, which has been reported with excellent correlation. And as you can see here, so for the fibrinogen, you can see that the level of the factor is decreasing and the severity is increasing. In the second group, there is a good correlation like factor 5, but it is not excellent as it is for fibrinogen. And if you look on factor 11, there is no correlation at all between the amount of the factor and the level of the severity. And for that reason, we think really on the patient with factor 11 deficiency, the levels of the factor is really not enough to give you the information and as a good prognostic marker for sending your patient to surgery. And there is also a publication which has been done by the SSCI-STH group trying to make the classification of rare bleeding disorder based on the coagulant activity. And as you can see, mainly the levels of the factor are not really similar for the severity of the phenotype. For example, for all factors like factor 7, factor 10, less than 10% was classified as a severe. And you know the hemophilia, less than 1% is associated with the severe bleeding. But in the rare bleeding disorder, things are a little bit different. For factor 5 and 8, and especially for factor 8, I would say less than 20%, and for fibrinogen, undetectable activity. And there is some limitation in the assay. We can go through it if you want. And here you can see the moderate cases for factor 7 and factor 10 is about 10 to 20% and 10 to 40% respectively. And for mild deficiency, usually when you have more than 10% for factor 2 and factor 5, they could be mild. And sometimes we have seen some heterozygote patient with factor 10 deficiency to be bleeder, and that is important, especially for the surgery. And that's the reason why has been classified that more than 40% in factor 10 deficiency is assigned as a mild deficiency. And for factor 13 is very different to what we thought previously, at least. Again, I'm just reporting there was limited number of the patient, and this number could change, but we have seen some patients with less than 30%. They were bleeders with factor 13, so that's the reason the levels of the coagulant activity associated to no bleeding or mild bleeding is a little bit different to what we knew. What about the assays, where we are standing, and how is the standardization of the assay? I would say there is a big problem because there are few types of deficiency, like fibrinogen deficiency and factor 13. There is a low accuracy for the low levels of the factor, and there is a lack of a standardization. However, the SSC subcommittee of factor 13 and fibrinogen, they are working on that. But for example, for the activity of fibrinogen, it's going to be really difficult to go lower than 20 or 30 milligrams of fibrinogen. And if you're going to make the prophylaxis in your patient, it's very important to understand whether your patient is not having at all any fibrinogen or there is 10 milligrams, and that makes a big difference. For example, if you use the berichrome assay, if you're not using the blanking associated to the berichrome assay, you're never going to go lower than 10 milligrams. But if you go with the blanking, you can distinguish those patients that are completely absent with the fibrinogen compared to those that something is there. And again, for your prophylaxis is a big difference and for your decision. What about global assays? That's very trendy. Everybody's trying these days to put the global assay. And whether these assays are the good indicator for the bleeding tendency is interesting because this assay is showing that the rate and total thrombin generated and actually showing the individual hemostatic capacity and is working on whole blood clot formation and the fibrin polymerization and on the clot structure and stability. Who is familiar with thrombin generation as and knows more and less, the parameter that should be considered are the lag time, time to peak, and ETP, endogenous thrombin potential. And it has been done few studies in this field. I'm reporting which was our experience a few years ago, I would say more than 10 years ago, and we got international red bleeding disorder plasmas of large number of patients and tried to see how was the endogenous thrombin potential. And we have seen that for having the half normal ETP here, it was really a big heterogeneity about the type of deficiency. For example, we've seen that 50% of prothrombin, 1% of factor 5, 2% of factor 7, and 5% of factor 10, and 1% of factor 11 was enough to give you 50% of the power of clotting. So that makes a big difference if you have to decide how you make your prophylaxis in future. And as a rule, the peak high was somehow more sensitive in our hand to clotting factor decrease than ETP. And again, I think this depends, and we need more study, because if you're making this analysis in a patient who is bleeding compared to who is not bleeding and not consuming, I would think these parameters are not exactly the same. And in our patients with severe bleeding symptom, the ETP was less than 20%. So that was a good parameter at that time to tell us at least whether we have to go for the genetic analysis or we can just classify our patients. And here you can see what I reported before in a more clear way, that the property of the thrombogram were correlated with the level of the clotting factor and the occurrence and severity of bleeding symptom in the case of inherited deficiency, and the very different level of the factors were giving us the same amount, 50% of the potentiality for the clotting. So is this assay standardized enough to be used in our practical clinical activity every day? I don't think so. I think this assay is not standardized yet, and SSC of ISTH is trying to work, especially in the patient with hemophilia and with all these different drugs that are coming to the market, but for the red bleeding disorder, actually more work needs to be done. The last point is how we are going to treat the patient once we make the diagnosis and what we have. And we know that there are two types of treatment, and you as a clinician have to know whether there is a case to treat the patient with replacement therapy, or you can just use the non-transfusional treatment, especially for mucocutaneous type of bleeding. Antifibrinolytic amino acid, especially in factor 11 deficiency, sometimes is going to be very useful. For the tooth extraction and for some circumcision, fibrin glue could be important. In the women with menorrhagia, the pills preparation would be estrogen progesterone preparation are important. DDAVP has been used. And as regards the replacement therapy, things are not happy as it is for hemophilia. So most countries around the world still are using the FFP and cryoprecipitate, I would say. The prothrombin complex is used for lots of deficiency like factor 2, factor 10 deficiency, and single factor concentrates are not easily available and prescribable in all European countries even. Here you can see the numbers that has been reported by World Federation of Hemophilia in 2012, and I tried to look the comparison between factor 8 and 9 to those of the red bleeding disorder. And as you can see, there is an increase of fibrinogen. For example, it was 1, now is 4, but not all available. Some of them, they are in clinical study at this stage. So how is the treatment of the patient? If you remember, I showed that the amount of the factors for making a clotting is different. So for that reason, probably you don't need the same amount of factor. But this table has been prepared by our previous knowledge, and still I think we have not really so much information to change it. But what we can say, usually when you have more than 20 or 30% of the factors a part of fibrinogen, you are in a good condition to be safe. Of course, if you have a patient that is in surgery and is consuming, the situation is a bit different. So you have to pay attention how frequently you're going to dose the levels of the factor and how you're going to keep that level of the factor. And that is changing with the plasma half-life of the patient. For example, if you treat a patient with factor 13 deficiency, one infusion, for example, for prophylaxis, a month is enough for a good prophylaxis. But if the patient has a big hematoma and is consuming, that amount is not enough, and the intervals should be shorter. If the patient with factor 13 deficiency is pregnant, the interval of 1 month probably is not enough, and you have to reduce it once every 2 weeks, or maybe every 3 weeks, I would say, is a long, 2 weeks, I would say. For factor 7 deficiency is the shortest half-life, and sometimes it is extremely difficult. And what's happening for the prophylaxis? The prophylaxis is not obvious as it is for hemophilia. It's obvious for example, factor 13 deficiency, because it's easy, because we have a very good results. But for all others, depends. And you have to see the frequency of bleeding, the risk of severe spontaneous bleeding, the risk of long-term disability associated with the bleeding of your patient, the CNS, GI, and joint bleeding, and also the levels that you are going to keep is going to be different. For example, if you have a patient with afibrinogenemia, so you want to keep your patient to have more or less about 70 to 100 milligram of the basic level of fibrinogen. How much fibrinogen you want to give? So if you give 70 milligram per kg, you are increasing up to 150. But how would be the best interval? Is really not enough and good information. The data are so different. And even on a large number of the patient with 100 afibrinogenemia, when we have looked, we've seen that in some patients is enough to give once every month, in some patients once every 2 weeks, and in some you need also once a week. And there was some of the thrombosis not related to the amount of the factor. So for fibrinogen, I would say is really individual, clinical history of the patient, thrombosis eventually, and bleeding is very important. For factor 7 deficiency, I personally start with once or twice a week, but I know that is ridiculous as in not enough. And sometimes you will end with once a day. For factor 10 deficiency, I start with once a week and keeping about 30% of the level. For factor 13, we already discussed. And for factor 11, you don't need to make any prophylaxis. The products here I wanted to show, the red one is what I previously showed you, and the blue one is what is increasing in the market. And you can see that factor 8 and 9 still are increasing, and with long-acting, there is no comparison. So that's an invitation for those patients and those manufacturing people who is in this room, that rare bleeding disorder require more attention from your side, and now we have good data collection from World Federation of Hemophilia and other collection like the European Registry, and you have more data to know where the patients are and what are the power of having which amount of the product. Again, I would end up with the same slides that I like, and I think the main limitation in this area is the lack of data, small population, limited personal clinical experience, and the scarce treatment availability. And I like what Dr. Lindberg was reporting, that good information is the best medicine when you are treating with a rare disorder. And the home take message is there is a heterogeneous association between coagulation factor activity level and clinical bleeding severity in patients with rare bleeding disorder. I think, as I reported, the global assays should be done as a research, but not used for the clinical activity. More detailed evaluation of each single factor deficiency is required, and this is a complex group of patients. We need the young people in this room who are interested in rare bleeding disorder to get one single deficiency and go through that. And with this one, thank you very much, and I'm happy to get 2 questions because we are in delay.